think when we look at this, we've seen a dramatic shift in terms of the guideline updates in bladder cancer over the last several years, right? And this is one of a hallmark shift that we've seen now where they're actually utilizing some type of MRD guidance, looking at these patients being able to achieve a complete response, a pathological complete response, to really be able to guide subsequent treatment decision making. I think when you look at the bladder cancer patient population, there's something that's extremely important to know. A lot of these patients are older, and a lot of these patients, when they make it to the metastatic setting, while the metastatic setting has really had a lot of significant updates over the last several years, the 5-year overall survival for patients with locally advanced or metastatic urothelial carcinoma is still under 10%. It's hovering right there between 5 and 10%. So the goal as we approach these patients in non-muscle invasive and even muscle invasive bladder cancer, our goal is to really try to achieve the best event-free survival that we can. I know we're going to talk about it, but just recently there was even an approval in utilization of enfortumab vedotin in combination with pembro that has just gotten extended by the FDA as neoadjuvant treatment prior to these patients going to surgery. So now it's really exciting that we can, after these patients undergo some type of cytoreductive therapy, let's say dose-dense MVAC, or even if they go with enfortumab pembrolizumab, they go on to a radical cystectomy and pelvic lymph node dissections. But then we assess them, and to see it's no longer just having, being unable to detect disease, but now we're getting down to that cellular level, right? And then what we've seen from the clinical trials, and obviously that's driven these NCCN guideline updates, is that these patients that don't achieve a negative PCR, they're ultimately put on, or should be put on, some form of immunotherapy, atezolizumab specifically, because it is one of the ones that's FDA approved. But it's something very exciting. And what we have seen is that those patients who go on to immunotherapy, who did not achieve a negative PCR, their event-free survival is much, much higher from the IMvigor 011 study, and we'll talk more about that as well. But this is something very exciting, right? And the goal, again, when you are in non-muscle invasive and muscle invasive, is to try to cure your patient and really try to avoid progression to that metastatic locally advanced stage. So when you look at the patient population that's ctDNA positive after a radical cystectomy, it is estimated that they have anywhere from a 6 to 20-fold higher likelihood of disease recurrence than those who are ctDNA negative. We know that the ctDNA negative population in general has improved disease-free survival as well as overall survival. And that goes back to a lot of the points that I mentioned when we're treating this muscle invasive bladder cancer population. So I do think that those patients, after they undergo neoadjuvant treatment, they undergo surgical removal of their bladder, the quintessential patient that is an ideal candidate for adjuvant treatment is really going to be that particular patient that is ctDNA positive. ctDNA positivity, from what we learned from IMvigor 010 and also 011, they both showed that the utilization of immunotherapy in ctDNA positive patients does lead to a significant improvement in event-free survival. It was almost a doubling of the event-free survival in those patients who received atezo versus standard of care, I would say, which is just active surveillance. So it's something that's very, very exciting. And I think that ideal patient is the ctDNA positive patient, where we should be utilizing something like an atezolizumab. While we know that ctDNA positivity is a poor prognostic indicator in many of these patients, the NCCN explicitly states, and the literature is just not ample enough yet to allow us to utilize ctDNA negativity to say that we're going to de-escalate therapy for these muscle invasive bladder cancer patients, or even consider not doing a radical cystectomy in these patients. That is still the hallmark gold standard of care. Regardless of what you do in the neoadjuvant setting, these patients still have to go to surgery. I would say with more mature data, as we look more and more into this, could that be an option down the line? Because these patients undergoing a radical cystectomy is extremely debilitating, and their quality of life is significantly impacted over a long period of time. But we have to be considerate. ctDNA can come back with false negatives. So we don't want to run into that scenario where we have a false negative. Sometimes the sensitivity of the actual test remains imperfect. A lot of these patients might have tissue scarring. They could have recurrent bladder infections and various things where even make sampling a little bit difficult. So right now, I would say ctDNA should be utilized if it is positive, it should be utilized as a high-risk indicator for the likelihood of recurrence post-surgery. But where we are today, I would not recommend, and the guidelines generally don't recommend, utilizing ctDNA negativity to de-escalate treatment. I would say maybe an area potentially where you could de-escalate treatment, or maybe just consider putting patients on active surveillance, is that you've done neoadjuvant therapy, the patient's underwent surgery, and maybe at that point in time, the patient is not interested in adjuvant treatment, right? So for a very long time in muscle-invasive bladder cancer, we didn't do adjuvant treatment, right? They went on to neoadjuvant chemo, underwent surgery, and were under active surveillance. Depending on what you did in the neoadjuvant setting, if you do enfortumab and pembro, you should be utilizing it in the adjuvant setting. But if you did something like a dose-dense MVAC, for example, you're not going to put these patients on enfortumab and pembro in the adjuvant treatment, but you do have options like nivolumab or atezo, like what we talked about. But nivolumab is approved as adjuvant treatment regardless of ctDNA positivity or negativity, right? But that could be an area, but still nothing in terms of de-escalation or assuming these patients aren't surgical candidates.
So I think this is an excellent question because it is an important opportunity to really clarify the current NCCN guidelines regarding minimal residual disease monitoring. This is a very specific guideline to patients who did not receive immune checkpoint inhibitor prior to radical cystectomy, and this is all based on the eligibility criteria of patients enrolled to the IMvigor011 study. So these guidelines are really narrow in the context of the evolving landscape of muscle-invasive bladder cancer management. And like you said, we are now taking a much more aggressive perioperative approach that incorporates checkpoint inhibitor therapy both before and after surgery. And so in those regimens, by definition, perioperative management implies continuation of therapy postoperatively. In the case of NIAGARA, that involves continuing durvalumab. And in the case of the Keynote 905 and Keynote B15 studies, that includes continuation of enfortumab vedotin and pembrolizumab. We just don't have enough data about whether ctDNA testing does carry the same actionable weight in these settings, but we do know that these studies were designed as a perioperative approach. And so in these trials, regardless of pathologic status at the time of radical cystectomy, patients continued on to receive adjuvant therapy. And all of these studies were positive studies that benefited patients. And so I think in the perioperative setting, we do need to be mindful of the fact that continuation of adjuvant therapy is a standard currently, and we do not have sufficient data from ctDNA results to inform whether we can change that at present. I think that there are some data from both the IMvigor011 study as well as other studies that have shown that ctDNA negative patients do tend to do better in general. In the IMvigor011 study, there was an exploratory analysis of those patients who actually didn't enroll to the study but had persistent ctDNA negative status. And these patients had excellent outcomes with 1-year disease-free survivals of 95%, excellent overall survival. The issue is that you need to be able to predict who is going to have persistently negative ctDNA based on that. And right now, we don't know who the patients are that are ctDNA negative initially, who will remain persistently ctDNA negative. And that's further complicated by the fact that we have trials like CheckMate 274, which was a positive study that demonstrated that nivolumab was better than placebo in patients who had received radical cystectomy and had YPT2 or higher disease or PT3 higher disease after radical cystectomy, regardless of ctDNA status. So I think we still have to offer nivolumab to these patients. And I think we need more prospective studies to look at further de-intensification. These studies are ongoing in trials like the MODERN study, where patients who are ctDNA negative are randomized to receive nivolumab or observation. So I think we will get these results, although they are a couple of years off still. I can talk personally about my opinion that real-time serial ctDNA monitoring is a really exciting prospect. It just needs to be studied more and incorporated into trials moving forward. I think there are some data from the NIAGARA study. Again, this was a study that looked at gemcitabine, cisplatin, and durvalumab versus gemcitabine and cisplatin prior to radical cystectomy. And this trial incorporated ctDNA monitoring into the trial and has released some results that showed that plasma ctDNA clearance it was favorably prognostic. It did not perfectly correlate to a pathologic complete response. They also looked at urine tumor-informed DNA, and that actually did better correlate with pathologic complete response. And there are retrospective studies that have shown that tumor-informed ctDNA may provide more prognostic impact than even pathologic complete response. So again, it's very exciting. We're not there yet in terms of standard guidelines that we can come up with based on the lack of data that we have. But I think there's a lot of opportunity for bladder-sparing trials to incorporate ctDNA monitoring into their algorithms. And I know studies like the S2427 BRIGHT study is incorporating ctDNA into this, and we will get more data in this area. I think the one thing that I do need to caution about here is that we have a real limited set of prospective data in this context. And so there is a lot of things that we must consider regarding potential anxiety and uncertainty that we're causing for patients as well as providers, because we don't have enough data to fully interpret the results that we're receiving or act upon the results that we're receiving. And that can lead to a lot of uncertainty and anxiety for patients. And so I think we do need to be mindful of that. And again, while I'm very excited about this, I am hoping that we'll have more prospective data that will help guide us. So I think that this is another area that's evolving currently. And I kind of liken it to the use of AI, which people are very excited about, but ultimately it's not really meant to replace, it's meant to augment. And I think similarly, ctDNA might be something that will augment rather than replace our current staging and selection of patients for bladder preservation. And how we define a complete responder is really important in the context of ctDNA, because when we're talking about bladder preservation therapy, if a patient is truly a complete responder with ctDNA negativity, does that mean that they shouldn't receive bladder preservation therapy? Or does it mean that those are the patients most likely to benefit from bladder preservation therapy? We really don't know right now. And so I think, again, the fact that ctDNA monitoring is being incorporated into the ongoing bladder preservation trials will answer some questions, but I think we're going to have even more questions about whether we can use it as a tool to identify people that need less therapy.